Welcome to the Fitness Simplified podcast. I'm Brooke Davis, women's functional nutritionist and fitness specialist with Elysian Women's Wellness, and I'm here to simplify your fitness.
The content provided in this podcast is for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health providers with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. Any information provided about nutrition, supplements, or fitness is based on personal experience and should be discussed with your healthcare provider before making any changes to your diet or lifestyle. Remember, your health and well-being are unique to you. What works for one person may not work for another. So always consult with your medical professional to determine what is best for you.
Today, I want to take a deeper dive into a topic that, I'll be honest, I'm not a complete expert in, but I'm learning more and more daily. And I want to share what I've learned because there are some raging myths and misconceptions surrounding this topic that are keeping middle-aged women from optimal health. And not just that, it's keeping them absolutely miserable. And that is hormone replacement therapy, HRT, or menopausal hormone therapy, MHT. So to start, I want to give some definitions. So perimenopause is defined as the 10 years or so prior to the complete stopping of your menstrual cycle for 12 months. And this comes with fluctuations and decline of our main sex hormones, estrogen and progesterone, leading ultimately to a complete failure of the ovaries to produce either. The 12-month mark on that day is considered menopause, and anything after that day is postmenopausal. Most women are absolutely miserable during this time. They're dealing with hot flashes, weight gain, muscle pain, joint aching, fatigue, brain fog, so much more, depression, mood swings, etc., that seemingly come out of nowhere and that nothing will resolve. Most women are either being dismissed by their doctors, with some refusing to do any kind of testing, offering up some anti-anxiety or antidepressant medication, maybe some doing some testing, but then saying there's nothing to be done, or worse, offering birth control, and a small percentage offering the support of hormone replacement therapy, but an even smaller percentage who are actually very knowledgeable and trained on the topic, because of course this is not included in general medical school. Perimenopause and menopause is kind of the black hole of healthcare, and while it's getting better, this is a population that has been completely overlooked when it comes to research and development, which is partly why I began my mission to help this demographic. This brings me to what I believe, in addition to diet, exercise, and lifestyle, of course, those cannot be overlooked, but to be the number one thing that perimenopausal and menopausal women can do to support their health, longevity, and quality of life. And that is hormone replacement therapy. So the basics of HRT, what it is, how it works, what are your options. We're going to go over so much of it. So hormone replacement therapy is literally what it says. It's the replacement of hormones that the body is struggling to make or no longer makes in order to help restore hormone levels that naturally start to decline as we approach menopause, and to bring back balance in the body because we need those hormones. During perimenopause, hormone levels, specifically estrogen and progesterone, become pretty erratic, and I want to explain why this is just for some context. Follicle stimulating hormone, or FSH, is one of the main messengers between the brain and the ovaries, and the best analogy I've heard is to think of it as a thermostat system, where the brain is constantly trying to read the temperature of hormone levels and respond in order to keep things balanced and keep your body in homeostasis. But during perimenopause, this thermostat starts to malfunction a little, leading to spikes and dips in hormone levels. Here is just a quick breakdown of how this system works and why it changes in perimenopause. So the pituitary gland in the brain is what produces FSH. It sends it to the ovaries, and FSH tells the ovaries to release an egg or mature a follicle. So the ovaries respond, they mature a follicle, hence the follicle stimulating hormone, which releases an egg and produces estrogen. As estrogen levels rise, the brain detects that and lowers FSH production, being like, okay, the job is done, keeping this system in balance. But as the ovaries become less responsive, less ability to respond to that cue of FSH, it won't always release an egg, and it doesn't always produce estrogen or enough estrogen. This is what then tells the brain it needs to turn up the thermostat because it's cold, so to speak, right? And release more FSH. But then it overcompensates, dumps a ton of estrogen into the system, and so now your brain is trying to turn down the thermostat and re-regulate that temperature. So these spikes and drops and fluctuations in all of those hormones are what is responsible for a lot of the symptoms that women feel in perimenopause, like hot flashes, night sweats, mood swings, sleep disruptions, all the things. And so the goal of HRT is to ease those symptoms by supplementing the body with hormones that it needs to bring it back into a stable, more balanced place. There are a few different types of HRT, and the main types of perimenopause are estrogen and progesterone, sometimes testosterone and DHEA. But we're mainly going to talk about estrogen and progesterone today because this podcast is longer. The hardest thing about HRT, and similar to macros, honestly, is that it's completely individual to the woman. So this is why you've heard maybe someone say HRT didn't work for them. It only just means that you really haven't found the right combination for you, or of course you have some prior medical history and things like that that is contraindicated. So we'll get to that. But this is literally trial and error. So even with blood tests to above to explain with the erratic fluctuations, it changes throughout perimenopause. So no two people will need the same dosages, and it might change, or does change generally. So some people might just need estrogen. Some people might do better on a combination of estrogen and progesterone. Some might need testosterone, and then it might change every few months, honestly. So this is why a lot of doctors don't want to mess with it, along with some of the studies that we're going to get to at the end. But there are two main types of HRT. That is bioidentical and synthetic. Bioidentical hormones are structurally and chemically identical to the hormones that your body naturally produces. They're mostly made from plants, and they can be custom compounded for individualized dosages. There is also pharmaceutical dosages that come in set ones, so there's a lot of variations there. The other option is synthetic hormones, and these are similar, but they do have a slightly different chemical structure from our natural hormones. They are FDA approved. They've been used for a long time. They've been used the longest, ultimately. They are what is found in birth controls and some of the first hormone replacement therapies. Synthetic estrogen can go by many names like estradiol acetate, synthetic conjugated estrogens, esterified estrogen, whereas bioidentical will just be called estradiol or estrogen. Synthetic progesterone is actually called progestins, while bioidentical are called progestogens. So this is some specifics to kind of pay attention to when you are looking at, not only the research, but of course your own prescriptions. So this does not include the brand names of the products that are delivered by Prometrium is the most common bioidentical progesterone pill. Estrace is one for estradiol. So that being said, there are several ways you can take HRT, and each comes with some pros and cons. Ultimately, it's about finding what best fits your needs, lifestyle, preferences, all the things. So we are going to talk about all of the options right now. So first off is the pills. Obviously, some of the pros, they're easy, familiar, just like any other medication. There's a set dosage each day. Sometimes for progesterone, maybe only take it half the day out of the month or couple weeks out of the month. Some of the cons of that is one, that you have to take it every day. And then oral estrogen is processed by the liver, which can increase the risk of blood clots. So if you're already at risk for that, then it may not be the best choice. And then of course, because it does have to be processed, through the stomach, it can sometimes cause nausea or upset stomach. There is patches. Obviously, the pros is that it sticks to your skin. It gives you a steady dose of hormones over time. You don't have to mess with it. They do bypass the liver, so these are transdermal, and so it lowers your blood clot risk, and they'll usually stay on for a few days at a time. Cons are that some people will find it irritating to the skin. If you have sensitive skin, they can sometimes come off if you sweat or swim, so if you're training like you should be, this might be a little more difficult. There are creams and gels. Obviously, these can be just applied directly to the skin. You can adjust the dosage as needed without having to go back to your doctor. They're easy to use. They just absorb through the skin, so they don't go through the liver, again, decreasing that risk of blood clots. Some of the cons are that absorption rates do vary depending on your skin type, and you do need to be careful not to let others touch the area immediately after applying the cream or gel. A common source of increased estrogen in older males is their wives' estrogen creams, so that's something to be aware of. For progestogen specifically, also, creams have not been proven to be sufficient to preventing endometrial thickening of women taking systemic estrogen. So we'll get into this a little bit later, but this can increase your risk of endometrial cancer. So if you are taking systemic estrogen, you need something stronger than a cream to deliver your progesterone. FYI. And then there are hormone pellets. A lot of people love these. These are custom compounded pellets containing estrogen, progesterone, and testosterone, and or all of the above, or a combination of them. So it's inserted under the skin, usually in the hip or glute area. And these are nice because they provide a long, consistent hormone dosage. It's steady, continuous release of hormone over several months. And this can help avoid the fluctuations that sometimes comes with pills or, creams, things like that. But with that, they do tend to fade as it comes time for the new dosage. So obviously they're convenient. They can last anywhere from 3 to 6 months, depending on your needs. So you don't have to worry about the daily dosages, pills, creams, that kind of thing. But like I said, as you come toward the end of your prescription, the effects do tend to fade a little bit. Some of the cons outside of that, they do require surgical insertion. So they do have to, cut a little hole in you and stick it in there, but it's a local anesthetic. It can be a little bit uncomfortable. There is, of course, a small risk of infection, pellet displacement, but it's not super common. And then the dosage adjustment. So once it is inserted, it is difficult to change the dosage. It has to be surgically removed if it's, really bad, which you can do, easily with pills, patches, creams, that kind of thing. So you would either need to wait till the pellet completely dissolves or have another procedure to remove it. The other thing with this is that some women experience this initial surge of hormones after the pellet's inserted, which can lead to some side effects like acne, mood changes, that kind of thing. And it also can absorb more hormones during high periods of physical activity, which again, you have those fluctuating levels, which is what we're trying to avoid. So again, it's about finding what's best for you. And then there are vaginal rings. So some of the pros, if you are dealing mainly with vaginal dryness, discomfort, since they release estrogen directly into where you need it, this is ideal. There are options that don't also raise systemic estrogen. So if that is an issue for you, then that can still be beneficial for GSN symptoms, genitourinary syndrome, like dry vaginal dryness, leakage, things like that. And then there are vaginal rings that are a higher dosage and will be systemic. The cons for that is that you do have to insert and deal with a ring. Some people find it uncomfortable, and some find the delivery method to not be as effective as others. So this next one is not very common, and some doctors might tell you about it. This is just something that I learned from different people, but the anal administration of progesterone. So the same capsules that can be taken orally can also be administered anally, which some women do find to produce better results due to the fast absorption of them. Some cons. I'm not sure I have to go deep into this part, but some women do find that it can aggravate the sensitive skin around the anus over time, so using generous amounts of lubrication is advised. And also, of course, talk to your doctor about that. Sublingual drops. So these are super convenient. They make it easy to control the dosage, variations, change them quickly. They are fast-acting absorption. It does bypass the liver. You may take some in, which can be an issue, and then there is less gastrointestinal side effects. Some of the cons can be inconsistent absorption because of swallowing some of it, saliva, that can impact how much gets into the bloodstream. They also act really fast, but they have a shorter duration. So you might need to take them multiple times per day. And then they can taste really strong. Next, we're going to get into some of the symptoms that can be reduced or managed with HRT, MHT. MHT, HRT can give women in perimenopause relief for many common symptoms and actually plays a huge role in their overall long-term health. Some of the most common symptoms are hot flashes and night sweats, or those intense heating, sweating episodes. And if it happens at night, they're called night sweats. So these are mostly due to fluctuating estrogen levels, which affects the brain's temperature regulation, literally, not just figuratively this time. And then progesterone can also play a role, especially for women who can't take estrogen alone, which we'll talk about shortly, or women who are having trouble sleeping because of night sweats and other issues. So if you're low in progesterone, that can cause a whole host of sleep issues as well. Perimenopausal depression and anxiety is very often misdiagnosed and prescribed an antidepressant or an anti-anxiety medication for, when what they're really missing is estrogen. Estrogen receptors are all over the body and in the brain, and estrogen helps stimulate areas of the brain related to memory, cognition, and it boosts neurotransmitter activity and blood flow. So estrogen replacement can increase cognitive function, focus, memory, all by restoring balance to those hormones. Perimenopause is also known to bring on mood changes. I know a lot of women just feel like an emotional roller coaster from irritability, sadness, anxiety, depression. And this is because both estrogen and progesterone affect neurotransmitters like serotonin. So having estrogen replaced can help stabilize your mood, reduce anxiety by supporting that serotonin production. And it's especially helpful for irritability and sadness. And then progesterone is known for its calming effect. It interacts with GABA receptors, and GABA is the neurotransmitter that helps you feel relaxed. So this can make progesterone helpful for reducing anxiety, helping you just chill out overall. And then vaginal dryness, sexual discomfort, again, really, really common, and it is purely due to lower estrogen levels. This decreases the lubrication, elasticity of the vaginal tissues. So estrogen, especially in localized forms like the creams, rings, tablets, that can directly improve moisture flexibility in the vaginal tissue, can also reduce the risk of UTIs, which become more and more common with the lower estrogen levels. And sleeping, which I touched on, but this can be huge and so disrupting in so many other aspects of life. If you're not sleeping well, nothing is going well. But the drop in estrogen, like I said, leads to night sweats, and that can cause people to wake up multiple times per night. And then progesterone plays a role in getting you back to sleep, getting you to sleep, then back to sleep after waking up, and it helps you stay asleep because of that natural calming effect. Bloating is one of the biggest complaints, and this is common because as estrogen fluctuates, this affects your fluid balance, your rate of digestion. Sometimes it slows down, which can lead to gastric distress that a lot of women are experiencing. And then we actually have a whole community of bacteria in the gut called the estrobolome that helps regulate estrogen. So when this is out of balance and estrogen isn't broken down or eliminated like it should be, this causes more of it to be circulating in the body, also causing some of those common symptoms. Of course, we want to support the gut with high fiber foods, probiotics, and supporting our detox pathways, but HRT can help reduce the intensity, frequency of those bloating episodes, helping you feel lighter, more comfortable, just simply by stabilizing estrogen levels. Estrogen also helps regulate fluid balance and protects our muscles and joints, which is part of why we start to lose muscle mass in perimenopause. Up to 10 pounds of muscle mass from perimenopause to menopause, which is huge. So going into musculoskeletal issues like frozen shoulder, achy joints, muscles, Dr. Vonda Wright just published a study on the musculoskeletal syndrome of menopause, and this states that more than 70% of women will experience musculoskeletal symptoms and 25% will be disabled from them through the transition from perimenopause to postmenopause. That's crazy. Estrogen is crucial for maintaining your joint health and flexibility because it helps to reduce inflammation, supports your collagen production in the connective tissues. As always, motion is lotion, so staying moving is also going to help support the joints, but estrogen therapy can help alleviate stiff joints, joint pain, even issues like frozen shoulder, which so many women experience it during these shifts. On the skeletal side of things, bone health, osteoporosis prevention, estrogen is the key hormone that protects your bone health. So when estrogen levels decline in perimenopause, the rate of bone loss increases more than 2% per year, putting us at a much higher risk of developing osteoporosis. HRT with estrogen can help slow the rate of bone loss, it reduces the risk of fractures, and supports overall bone density by helping the body retain calcium and other important minerals within the bones. This, of course, is supported by proper resistance and impact training along with adequate nutrition, but estrogen replacement can't be completely overlooked. Next, we're going to get into some of the myths and misconceptions around MHRT you've probably heard. So starting with kind of a combination of the first ones is that HRT isn't safe, estrogen causes breast cancer, estrogen and progestrogens increase your risk of breast cancer. So we're going to dive into the studies that these came from. The main study and the one that all of this danger came from the Women's Health Initiative, and it was published in 2002. And this is, like I said, the one that most people who have the misconception that HRT is dangerous, or they are still referencing this study. This has since been walked back even by the Women's Health Initiative themselves. So let's go over it. The study included about 16,000 postmenopausal women who were given either a combination of Premarin, which is horse urine derived estrogen, and Provera, a progestin, which is a synthetic form of progesterone, or a placebo, a pill with no active ingredients, to see if HRT could help prevent heart disease, fractures, and certain types of cancer. When the initial findings were released, there was major concern because the study suggested that women taking HRT had a slightly higher risk of breast cancer, heart disease, stroke, and blood clots compared to those taking placebo. It actually was largely exaggerated. They wasn't just slightly, they said that this was the fact. So doctors, of course, were taking their patients off of it, women stopped taking it, and everybody was afraid of it, but basically for the last 20 years. So here's what it was, to put this in a little perspective. The worst of it increased the risk of breast cancer by 9 additional breast cancers per 10,000 women after 5.6 years, or 1 out of 1,000 users, which is just slightly greater than what we've seen with 1 daily glass of wine, less than 2 daily glasses of wine, and similar risk as reported with obesity and low exercise. Take note, the increased risk was also seen in women who had prior exposure to hormone therapy. For any women who had not ever had hormone therapy, there was 0 increased risk. They continued estrogen only in a group of women who didn't have a uterus, and when compared, these women actually had a lower risk of breast cancer as well as bone and cardiovascular benefits. So, in the years that followed, researchers started to question the conclusions of this study. And here is mainly why it's seen as largely misleading. So, most of the women in the study were in their 60s and 70s, which is now contraindicated or a contraindication for starting HRT, which we'll get into later. They were not in their 40s and 50s, which is the age when typically women start perimenopause or early menopause and should begin HRT. Since then, like I said, we have seen that age and timing matter, which with younger women seeing more benefits and fewer risks. So most women over 65 are not typically advised to start MHT, but as always, it's worth a chat with your doctor if you're low in other risk factors. Another thing was the type of hormones used. So the study used synthetic progestin, not a bioidentical form of progesterone, and a form of estrogen derived from horses, which we now know might act differently in the body than forms of estrogen bioidentical forms of estrogen and progesterone. So newer research and reanalysis of this study. So when they looked at the data again, they found that women who started HRT within 10 years of menopause, there was actually a lower risk of heart disease and no significant increase in breast cancer risk. In another WHI observational study looking at estrogen-only women who had had a hysterectomy, after 8.2 years, invasive breast cancer risk did not differ when comparing dosages or delivery when it's delivered in the first 10 years of menopause. This being said, transdermal estradiol may be slightly less risk than oral when it comes to the blood clot risk, but the sample size was really small. Then JAMA, the Journal of American Medical Association, in 2020 took that WHI long-term data. This was a 20-year follow-up analysis. So estrogen alone reduced incidence of and mortality from invasive breast cancer, while combination estrogen and progestin therapy elevated incidence of, but not mortality from, breast cancer, even in women with a family history of breast cancer. So even with these statistics, what we're looking at with combination therapies of suboptimal types of hormone therapies, being that they're not bioidentical, is that it would be responsible for less than one additional but non-fatal breast cancer diagnosis out of every 1,000 women who are treated with menopausal hormone therapy. Here are some other studies. So these are smaller randomized control trials of Menopause 2023, show that it reduced the risk of breast cancer. There was a nurse's health observational study, 5 to 9 years, no increased risk. Over 20 years, there was slightly increased risk. The Million Women study, this was a survey study, which is the least reliable form of studies. They did see a 35% increase, but as you can see, this is a total outlier. Other things, so vaginal estrogen in low dosages for genitourinary syndrome, menopause like vaginal dryness, leakage, etc. This is purely local, and it's such a low dose, there's no impact systemically, so there was no increases in breast cancer risks. The next myth is that women over 60 should stop HRT. There was a new study released in April 2024 that was an analysis of 10 million senior Medicare women from 2007 to 2020. The results were that estrogen alone beyond age 65 was associated with significant risk reductions in mortality by 19%, breast cancer reduced by 16%, lung cancer reduced by 13%, colorectal cancer reduced by 12%, congestive heart failure by 5%, blood clots by 3%, atrial fibrillation by 4%, heart attack reduced by 11%, and dementia reduced by 2%. Estrogen and progesterone combo therapy increased risk of breast cancer by less than what the WHI came up with, but it could be mitigated by using that low transdermal estrogen or vaginal systemic dosage. Estrogen plus progestins, the synthetic form, showed reduced endometrial cancer by 45%, reduced ovarian cancer by 21%, reduced ischemic heart disease, which is the narrowing of arteries, by 5%, reduced congestive heart failure by 5%, and blood clots by 5%. Estrogen plus progestogens was only seen a risk reduction, did only see a risk reduction in congestive heart failure by 4%, but there was no increase in any other issues. That being said, there are 3 French observational studies that looked at 2,354 cases of invasive breast cancer in a group of 80,307 women, postmenopausal women over 8 years, and they found that estrogen plus progestins, the synthetic form, had a slightly increased cancer risk more than estrogens and progestogens, the bioidentical. This being said, proven progesterone dosages for endometrial protection is 100 milligrams daily with average or less than average estrogen, or 200 milligrams 12 days out of the month. Above average dosages of estrogen may require higher dosages of progesterone for endometrial protection. The conclusion of all of this was that among senior Medicare women, MHT use beyond 65 years varies by types, routes, and strengths. Risk reductions appear to be greater with low rather than medium or high doses, vaginal or transdermal rather than oral with E2, which is bioidentical rather than Premarin, but this also hasn't been proven in randomized controlled trials. Which is the gold standard of studies. These were from the observational studies. So that is the conclusion of those. The reality of it is that after age 65, risks are increased. So if you are taking oral estrogen, it is advised to switch to transdermal due to the blood clot risks and reduced metabolization of hormones. You should be on the lowest effective dosage, which you should be anyway, anybody at any age. And then, of course, weighing the risks and benefits, looking at your overall health, from metabolic health to osteoporosis, etc., is something that you talk to your doctor with. Starting MHT after 65, again, is not generally advised, but of course, talk with your doctor. Some of the symptoms may be worth the risk. Vaginal local estrogen for genital urinal symptoms is approved at any time, but systemic hormones ideally are started within 10 years of your last period to help support urogenital atrophy, dementia, ideally within 5 years, and then cardiovascular disease. Within 3 to 6 years is best for bone loss prevention or treatment, and starting after 10 years does increase your risk of blood clots, stroke, cardiovascular disease, and dementia. The last myth. Birth control is the same as HRT. One very common misconception, by doctors even, is that birth control pills or IUDs and menopausal hormone replacement therapy are essentially the same thing. While they both involve hormones, they have vastly different purposes, different formulations, different effects on the body, especially during perimenopause and menopause. So, quick breakdown. Birth control pills are designed primarily to prevent pregnancy. So they contain higher levels of synthetic hormones, often estrogen and progesterone, to suppress ovulation. HRT, on the other hand, is designed for replacing and balancing hormones that naturally decline during menopause, continuing ovulation. The hormone levels in HRT are much lower than in birth control because the goal is not to prevent pregnancy or suppress ovulation, but we want to restore balance that can alleviate some of those menopausal symptoms. Another key difference, like I said, is the type of hormone used. So birth control pills, they're all synthetic hormones. They don't mimic the body's natural hormones as closely, whereas if you're using bioidentical HRT, it can feel more natural. It, like we looked at above, can have fewer side effects compared to the synthetic. And the kicker is that birth control can actually mask some perimenopausal symptoms, but it doesn't address the root cause, similar to what it does with younger people who take it. It doesn't fix the problem, it just masks it. And it can ultimately make things worse in the long run. It also can deplete the body of major nutrients and minerals. Long story short, don't let your doctor tell you that getting on birth control will solve your problems at any age. Honestly. The hardest part about menopausal hormone therapy is that no two women are the same. Their hormone needs, dosages will not be the same, even as someone experiencing similar symptoms. It is highly personal choice, obviously, to take this as is any prescription medication, and every woman's needs are going to be unique. So this is why finding a provider who can take your individual information, your medical history, your current symptoms into account, that also has education on hormone therapy is really important, but also really difficult. That being said, I want to give you some ways to best approach this decision, including how to navigate an appointment with your doctor, questions you can ask, things to consider, and steps you can take to feel really confident in your decision. So, number one is before you start HRT, you want to get a clear picture of your symptoms, your goals for treatment. So, tracking your symptoms daily for a few weeks, noting the severity, frequency, and any lifestyle factors that influence them, like your sleep, your diet, stress levels, alcohol intake, things like that. This can serve as your baseline so that you and your doctor can actually measure improvements and any side effects over time. I have linked a chart in the notes from the Menopause charity that can help you kind of keep track of things. Also, taking some time to actually define what success looks like, and we do this in coaching as well, but what it actually looks like for you with this treatment. So are you hoping for more energy, fewer hot flashes, improved sleep, better mood? Knowing really what you're looking for can help you make a more informed decision and allows your provider to help recommend the best approach or alternatives even for what you're looking for. Like I said, your health history is extremely important factor when considering HRT. So making a note if you have certain conditions like history of blood clots, certain types of cancers, liver disease, this may make HRT less suitable, but honestly not necessarily out of the question. Risk reward, how miserable are you? So obviously making sure to review your health history and any genetic predispositions with your provider. Making sure to know those, because a lot of times, even if they look at your charts, they're just overwhelmed and you have to be your own advocate. And then thinking about the different methods that you might want. Some may suit your lifestyle better than others, depending on how busy you are, your routine, your comfort with different applications. So making a note of which sounds most preferable to you and what to ask your doctor about. And then questions that you can ask your doctor. Obviously, what type of HRT would you recommend for my symptoms? You don't have to go and get it right then if you don't want to. You can take time to think about this. So ask what they would recommend. Like I said, some people may benefit from estrogen only if you don't have a uterus. While if you do have a uterus, you do need a combination of estrogen and progesterone. The best types depend on your specific symptoms, your health history, whether or not, like I said, you've had a hysterectomy. And then, of course, what are the potential side effects and risks? We've talked about some of the potentials today, but this will also vary based on your medical history and your genetics. Are there other supplements that could give me support for these symptoms? There is a whole host of herbal and nutraceutical supplements that may be beneficial to some of the specific symptoms that you're experiencing. I do have a Menopause supplement Bible guide if you want to explore that, but of course, always ask your doctor before taking anything, but I will link that in the show notes if you want some more maybe simple approaches to managing symptoms. Like I said before, it is really about finding what works best for your body, and it can take 3 to 6 months to really see resolution of symptoms once you find your correct dosage. So make sure to continue tracking your symptoms, any changes you notice, both positive and negative, so that you can help your doctor make the best adjustments. Deciding on HRT is not a one-size-fits-all process. Your needs, symptoms, preferences all drive the choice. With the right information, support from your healthcare provider, you can find a solution that works for you and helps you feel more in control of your health during perimenopause. Change is inevitable, but suffering is not. I hope this was all super helpful. I hope you feel more empowered to take on this conversation with your doctor and get the support that you need. If you are struggling to find a healthcare provider that is willing to give you HRT or you don't feel is a good fit for you, you can check out the resource. I will link it in the show notes to 3 telehealth HRT providers to see if any of those might be a good fit for you. I'm not affiliated with them in any way, but I've gotten good feedback from clients and people I know that have used them. If you need more support in navigating this, we do offer a free hormone analysis that I will also link below that we can talk over your symptoms. And then, of course, some of the most important and missing keys to this puzzle is the nutrition, exercise, and lifestyle habits that are also going to help support your goals.
Thanks for tuning in to this episode of the Fitness Simplified podcast. We are stoked to have you join us on your journey to better health and fitness. If you have any questions, suggestions for future topics, or just want to chat, feel free to reach out to us on Instagram at Brooke_Elysian and Facebook linked in the show notes, or via our website, ElysianWomen'sWellness.com. If you enjoyed what you heard today, we would be thrilled if you could take a half second to leave us a 5-star rating and review. Not only will you be helping others find our show, but you'll also be entered into our monthly $100 giveaway for new reviews. If there was something you heard that was helpful or impactful, please screenshot it, tag me, and share what it was so that we can bring you more. Plus, you'll be entered into our monthly Elysian Recharge post-workout giveaway. New episodes drop every Monday, so make sure to hit that subscribe button and stay tuned for more. Thanks for listening.